a few notices. NENC has been involved with a mass PPIE project called the Citizens Jury. It's been specifically on pain management. We've got several reports out, thanks there, Yo-Yo. And we are running an event on the 13th of November at Hilton Hotel, Newcastle Gateshead, to discuss what the process was, to celebrate the outcomes, and to discuss things further. So if you're interested in attending that, please register through Eventbrite. The link is in the chat and there's a QR code on the screen. Also, to let you all know that November will be the last time that NENC will be hosting this meeting. We will continue to provide admin support, but we're looking for hosts. So somebody to do my job, which is very, very simple. I just talk to nice people. So basically it's just chairing this meeting, finding speakers, and then giving an idea of what the themes might be. And to be honest with you, you tell me that, because we ask the audience to give us the themes that we want to hear about. So if you're interested, if you think you've got capacity, if you're working for an organisation who would like to get involved, do let me know. Just email me and I'll put my email address in the chat so people can contact me. So if we move on, so today we're going to be hearing from the Taper 2 team. That's James Prentice, Samina Hassan, Charlotte Papry-Clark, Angela Telford, Rachel Vincent and Thomas Love Dawn. So I will pass straight over to James and I'll just let you all introduce each other as time goes on. Thanks ever so much. Thank you.
Brilliant. Thank you. This is going to be the content of today. Hopefully this is going to be a really interesting hour or so, and hopefully we'll get a lot of questions and discussion at the end. Very briefly, an introduction to Taper 2. This was a 6-month project led jointly by our Waiting Well programme and our Deep End network, which we're going to go into more detail about. And then we're going to get on to the results, essentially, which are fascinating in my eyes. What I wanted to do just for the first 5-10 minutes was just give people an overview of the Waiting Well programme and what we've been doing within NENC to support our socially deprived patients preparing for surgery and to improve their well-being and health before elective procedures. Now, this all really kicked off during COVID. Or just at the end of COVID, and we all knew that the waiting times for surgery due to the pandemic were increasing. We had 36,000 patients on the elective surgical pathway, with a third of them within NENC in deciles 1 and 2. Everyone knew that COVID affected the most vulnerable communities the most. And there was some evidence within the patch around what we call prehab or optimization for surgery, but we lacked a united approach to how this was taken across the ICB. And this is a bit of work that's just been published in BMJ Open. I'll come on to how we got all this data because it's quite impressive. But what we know about deprivation is that you've got reduced access to healthcare, which leads to poorer health, which of course leads to worse outcomes. But we've got also this middle part where everyone is attending our pre-assessment units and being postponed or cancelled and not getting their operation due to the chronic comorbid disease of the population. And what we were able to show in big numbers, so this is all people either waiting their operation or waiting their first initial outpatient appointment with a surgeon. Every single comorbid disease was significantly higher in the deprived population, except for atrial fibrillation, probably because the GPs never had time to check their pulse because they're dealing with all their other issues on top of it. And this was despite them being significantly younger. So The Waiting Well programme was set up. We are part of the ICB's Healthy and Fairer board, who are our bosses and tell us what we can and can't do. We've got a number of work streams, including comms and finance, the evaluation team. We've got a central hub that pick up all the patients, and we've got 5 place-based delivery teams. And I'm going to be talking about the part that I run, which is the North ICP. It's a big area. It's Northumberland, North Tyneside, Newcastle and Gateshead. We've got 3 foundation trusts within our patch, so it's difficult, but the results have been outstanding. Now, underpinning all of this is the Radar dashboard. And essentially, for the first time, we've been able to merge primary and secondary care data together to give everyone an overview of what's going on, both primary care and us in secondary care. And it merges that elective waiting list data coming in onto GP records, so we can see what their last hemoglobin is on their last HbA1c, and we can then do something about it. And this is what TAPER has really been about. We've moved it forward. We can now risk stratify absolutely everybody based on agreed criteria from NENC into green, amber, red pathways. And this actually is now getting uploaded and being used within Newcastle to develop low risk pathways and optimization programs. So what's our current offer? So as I mentioned, we are supporting patients within 3 foundation trusts. It's a mix of psychosocial and clinical support guided by what matters most by the patients. Patients are offered either one-to-one support or signposting into other local services, and we have a number of bespoke interventions: smoking cessation, diabetes. We're going to come on to the high-dose opiate support or opiate support, weight management, etc., etc. And the things are just getting bigger and bigger as we go. So just sharing some of the other results, because this is always interesting. HealthWorks, another one of our VCSC organisations, support people on the more generic pathways, not specific like diabetes or opioids. But we're getting people moving more. We're improving their diabetes. We're improving their financial well-being. We're reducing their alcohol use, and we're helping them lose weight. And it's been quite a journey to get it to where it is now, but we're doing such good work, and it's really amazing to see. The big interventions are diabetes intervention. At the moment, we are postponing or cancelling everyone with an HbA1c over 69. And I thought we had to do something about this. So we took on 1.5 dietitians. We've bought in Freestyle Libre devices, and we're giving them a cookbook. That's the intervention. Now, it's brilliant. The whole digital aspect of this is great. We can get an idea of their their glucose control much better than we can get from a HbA1c or getting the patient to go away and check their blood sugars. We are predominantly, well, for this group, we are 74% of them are on insulin already. The vast majority are from deprived populations, and unsurprisingly, 82% have got diabetes. But we had 150 patients in the first year. 57 of that cohort have gone on to have surgery. In the second year, we're up to 150 patients who have now gone through their operation. And these are the results we're getting. Within about 6 weeks, their glucose control has improved significantly without the need for changing their medication, their oral medications. The vast majority of those on insulin are actually reducing, and it works out to us saving approximately 141,625 units a year coming through from just educating our population. So that's a very brief overview of where we are with our Waiting Well programme. It's been a lot of hard work. It's been a massive journey. It's hitting the 10-year plan. the learning has just been brilliant, and underneath all of this is data. And thank you to all the primary care team who have signed the data sharing agreements to allow us to actually get this data and to merge everything together. We have still got issues. Our success has been affected somewhat by patients still being cancelled and still being delayed, especially during the junior doctor strike. We had optimised all these patients and then they got postponed and cancelled. And so we have seen a number falling off the wagon, even when they'd made significant improvements. And it's something that we are currently working on to see how we can get around that. But the stories have been brilliant and they've really made me smile. The Taper 2 project has been amazing to be part of. And I'll hand you over to Samina to talk about the Deep End, because this was a real partnership between the Waiting Well programme and the Deep End network.
Hi, thanks very much, James. So my name is Samina Hassan. I'm a GP in Gateshead, and I'm the co-clinical lead of the Deep End GP network across North East and North Cumbria. So we're a network of just over 50 practices, and we aim to support our practices who are serving the most deprived, socioeconomically disadvantaged populations. The network is a much larger, is part of a much larger movement of Deep End network movements, which are across the country and globally. And we based our principles of membership and values on the original Deep End GP network model, which was started in Glasgow. So we've been working together for about 5 years now in partnership with public health colleagues from OHID and also research academics from Newcastle University and the NIHR Applied Research Collaborative, as well as commissioners, which has led to us having some funding through the ICB. We have 4 broad work streams which we try to target and deliver our aims. So that's workforce, education, advocacy and research. So we aim to support high quality and sustainable resilient general practice, because we understand that often patients that are living in areas of high socioeconomic deprivation, just like James has shown there, are still very much affected by the inverse care law. And the practices that are serving them are trying hard to address this by working in innovative ways where the funding might not really be directed to the areas of most need. So often our workforce pilots are looking at ways of trying to retain current team members and also recruit new staff into primary care and work in different and novel ways. Within our education framework, we're really trying hard to increase the exposure and reach of working in areas of socioeconomic disadvantage, from our trainee undergraduate medical students through our GP trainees, foundation doctors, and through to the newly qualified GPs. And often this is through face-to-face teaching events, through liaising with the vocational training schemes to have bespoke training rotations, but also through some fellowship options through the Deep End network. And so we advocate for delivery of care through the lens of proportionate universalism, and really trying to deliver the best care and look at initiatives that can help deliver care to the areas of most need, a bit like what Waiting Well has been doing with the Deep End network. And really try and use a member-led focused way of working by using population health data to drive change. We also have a really strong connection with our research colleagues, and we have dedicated support from Newcastle University and, as I said, the NIHR ARC. And we really try to co-design our pilot interventions, so we have a sort of hand-in-glove approach, and they can also help us look at the evaluation and the impact of the work that we've been doing, which we'll be talking a little bit more about. We also have a dedicated patient involvement and community engagement lead as part of our team, which helps us get some understanding of what it's like on the ground for the communities that we serve. So Taper was a pilot intervention that started as part of our workforce programme. It was because our network members had identified that their practices often had high socio-economic disadvantage, which was linked to high use of opioids, gabapentins, higher number of patients on these, higher doses, and some higher complication rates because of this. And often trying to deprescribe these medications were complicated, it took a long time, and often they were part of remunerated target-based work that the commissioners put out to practices, and the practices would struggle to achieve some of those target-based outcomes namely because of the number of patients that they had, but also some of the complexity that they had in terms of trying to deprescribe and reduce and go through reducing regimes. So one of the things that the DeepEnd network did was to give practices protected time of a session a week over a 6-month period to identify and review the list of their patients that were on high usages of opioid and gabapentins, work on a reducing regime, and improve the prescribing rate and the patient health outcomes. And Charlotte was evaluating this work as part of her role in the university, so I'll hand over to her to discuss the findings.
Lovely, thank you, Samina. So my name is Charlotte Barbary-Clark and I'm a consultant in public health, and I'm also an NHR doctoral fellow at Newcastle University. And so just in terms of a bit of context as well, so the prescribing of opioids and gabapentinoids have dramatically increased over recent years, and we know that the evidence shows that chronic pain is more common in people that are living with or living in places that are more socioeconomically disadvantaged, and that the prescribing rates and the adverse effects of these medications are also higher in more socioeconomically disadvantaged groups. We also know from the evidence that there's limited effectiveness of these medications in treatment of chronic primary pains, that pain without a specific cause. And as Samina was saying, DeepEnd practices serve some of our most disadvantaged communities and often have high prescribing rates of these medications. So we undertook an evaluation. There we go. And essentially it was a qualitative evaluation exploring the views and experiences of those primary care professionals in terms of their design, delivery and evaluation of that intervention that Samina talked about, with that 1 session a week over 6 months to plan, deliver and reduce their opioid and gabapentinoid prescribing in their GP practices in high risk, particularly in high risk patients. We used interviews and as well as observing peer support meetings, and we had 13 participants across 5 practices. And you can see there the key themes that were identified, and there's some sub-themes that come out underneath those, which I'm not going to go into too much detail today. But what I thought was going to be particularly useful is to talk to you about some key facilitators and the kind of key learning essentially that we found. So particularly having dedicated time was a real key component that the primary care professionals told us about, to really be able to look at what might work for their practices and their patients and then implement that. Also developing a rapport with the patients was crucial, and taking a person-centered approach with shared decision making was felt to be a key component of that. But that was a bit of a balance in terms of assessing and mitigating risk as well. But approaches that people often took was around understanding that patient's context, what's going on in their lives, why are they on these medications in the first place, and just understand a bit more about their lives, to understand perhaps what might be barriers with regards to their deprescribing journey. Explaining why deprescribing was now recommended, and also exploring patients' preferences, thinking about being flexible, looking at choices as well, and really sharing that decision making with the patients where safety wasn't compromised. Also having that approach that was agreed across the practice was really important, so that everyone was singing from the same hymn sheet. And that also included upskilling staff in terms of the ways to approach these difficult medication reviews and these difficult conversations, and perhaps also the alternatives to consider. And one other key component that came out was really culture change was required across the system to ensure success, so that patients shouldn't be on inappropriate doses of these medications for inappropriate lengths of time or for inappropriate reasons. And that really helping to enable patients to live well with chronic pain, but acknowledging that pain was complex and hard to cope with at times. There was also an emotional component to the work, that it could be difficult work, and often there were difficult conversations that came up when deprescribing, and that was particularly because patients were worried about the impact of the perhaps on their quality of life. But sometimes the work was easier and more rewarding than expected. And that's just a bit of a snapshot of what the findings, but if you want to go into more detail, you can go to the links there. And the recommendations were shared with the DPEN network, practices, commissioners, the wider system, and also were used to inform Taper 2 as well. I'll hand over to Angela. Thanks.
Thanks, Charlotte. So I'm Angela Telford and I'm a pain control nurse, and I was the lead for the Taper 2 project. So I'm going to tell you a bit about the project itself and how it ran, and then I'm going to go through some of the quantitative results that we got. So as you've heard from the people before us, we've already got the evidence there. We know that long-term opioids and gabapentinoids is harmful. We had the Taper project, which showed that deprescribing can work and can improve things for patients. And we know that surgical outcomes are detrimentally affected by the social deprivation and the pre-op analgesia use. And I've just put this information on this slide about how pre-op opioid and gabapentinoid use affects post-operative care and care during the surgery, because a lot of people understand that if you take a lot of painkillers before surgery, you're going to struggle with pain after surgery. But even healthcare professionals are often unaware of all the other effects that happen to your body when you take these drugs preoperatively. So people aren't often aware that you're more likely to die, you're more likely to go to intensive care, you know, you've got more anxiety and depression, you're less likely to go back to work, you're going to have problems with wound healing, risk of infection, things like that. So it's not just about the pain control, it's affecting the whole patient experience. So Taper 2, as we said, it's a 6-month project, and it was jointly funded by the Waiting Well team and the DPEN network. And we were concentrating on opioid and gabapentinoid deprescribing in pre-surgical patients. We didn't specify that it had to be high dose opioids or gabapentinoids. We just said any opioids or gabapentinoids. And there were 14 DPEN practices invited to participate, and they were asked to recruit up to 20 patients each, and they were given £150 per patient to help them manage this project. And we tried to keep it as simple as possible. So we identified suitable patients on the waiting list, so those taking opioids and gabapentinoids. We then offered social prescribing to support them. And don't worry if you don't understand about social prescribing, because we're going to talk about that a lot shortly. They were then offered a medication review, and we talked about reducing their analgesia if it was appropriate, because it wasn't appropriate for all of these people. And the whole idea was to improve their well-being preoperatively and therefore improve their surgical outcomes. I was employed 8 hours a week to coordinate and lead on the project, and we had 1.5 social prescribers per week to support the patients as well. So this is just to explain what social prescribing is in case you're unaware of it. So our social prescribers were provided by a company called Ways to Wellness. And as I said, Thomas from the Ways to Wellness team is going to talk to you about the social prescribing results. But this is just giving you an idea of the sort of areas that Ways to Wellness helped our patients. So they were looking at this holistic approach to the patients. What can they do to help make their lives better so that we can keep things on track. The different teams had different project roles. So the GPs were responsible for deciding which patients they were going to recruit, because the majority had more than 20 patients who fit the criteria. So they could choose who they thought were best suited to the Taper 2 programme. They were responsible for all the deprescribing and all the discussions with the patients. They then referred the patients on either to social prescribing or to lots of other teams. So, for example, some people got referred to the sleep apnea clinic, they got referred for weight management, things like that. And they were asked to collect some quantitative outcome data. The social prescribers provided the psychosocial support, and they collected and analysed all the qualitative data. So they did a lot of work around that. I started out by creating some resources for the GPs just to give them some information and some statistics about the risks. I helped them identify which patients would be most appropriate for the project. And then throughout the project, I provided support and advice and some education for the teams and the GP practices. And I did concentrate on the people involved in the project, but for the education point, we got everybody in the practice involved so that everybody knew what was going on, and we were just trying to improve everybody's knowledge about the risks of these drugs. I hosted regular Teams meetings throughout the project just to give support to everybody who was being involved. And then I analysed the quantitative data, and then I've been involved in sharing all the results with everybody. So 11 out of the 14 deep end practices were interested in participating. 9 completed the project. The 2 that dropped out, one was because they'd done really well with the original taper project and couldn't find enough patients to recruit. And then the other one, unfortunately, they didn't have the time to complete. But of the 9 who completed the project, they invited 198 patients to participate. And as I said, the GP's practices chose which people to invite. Of the 198, they recruited 127, so they got a 64% recruitment rate, which is really good. Age range was 25 to 87, but the majority of people were older, so the average age was 62 years. And when you look at the number of patients who are recruited, or that slide hasn't come up properly, but the blue lines are the number of patients recruited. So you can see some practices did better than others with recruitment. The orange is the number of patients who accepted deprescribing, and the green is the number of patients that accepted social prescribing. So some people accepted deprescribing and social prescribing, some just accepted deprescribing, and some just accepted social prescribing. And you can see, for example, practice 1, they got a lot of people for deprescribing, but not many for social prescribing. If you look at practice 6, they actually got more people for social prescribing than deprescribing. So we weren't forcing anybody to have deprescribing or social prescribing. We just encouraged them to have both. So these are the deprescribing results. So if you look on the left, that's the drugs that the patients were prescribed at the start of the project. So you can see the majority were taking morphine, codeine or gabapentin. The buprenorphine and the fentanyl were patch form. All the other drugs were a mixture of quick release and slow release drugs. But 90% patients accepted our deprescribing support, and of those, 46 also accepted the social prescribing support. And what's really interesting is, although we recruited them for gabapentin and opioid deprescribing, an additional 3 patients on top of the 90 accepted deprescribing for other drugs. So the other drugs were amitriptyline and temazepam. So they weren't included in the project results, but actually it made the GP practices and the patients really think about the drugs that were prescribed. Average number of appointments of reviews was 3, but it ranged between 1 and 6. So obviously some people needed more support than others when they were cutting down their drugs. Some patients, the GPs found quite straightforward. Other patients needed a lot more support, and it was a lot more complicated. And these are our actual deprescribing results. So if you look at the top green bar, that's the amount of each drug that was discontinued. So you can see we had really good results, bearing in mind that a lot of these people had been taking these drugs for a long time. Most of the drugs were reduced by more than 50%, and we had quite a lot of people who, you know, they really engaged with this progress, and they were really positive about it. So every single drug, we saw a really positive reduction in the amount that patients were taking. So the deprescribing practice range, the practice that was the least successful with deprescribing still managed to get a 48% reduction in the opioid and gabapentinoid prescriptions. And the practice that was the most successful got a 90% reduction in the prescribing, which is absolutely fantastic. But overall, it was a 64% reduction in analgesia prescriptions so far by the end of the project, because obviously for some patients, the deprescribing is a very long process, especially if they've been taking high doses of drugs for an awful long time. Some of these patients have been taking drugs for 20 years. So it was a big change, and it had to be a slow process. So the deprescribing is still ongoing. What's really interesting is that 27 patients completely stopped taking their analgesia. So 30% of the people who accepted deprescribing stopped taking their opioids and gabapentinoids completely. And then, just as an aside, there was one patient who stopped their temazepam, although that's not included in these results. I think it's really interesting to know that. And the recognised benefits that we got was that obviously there's a positive impact on the patient health and the recovery from surgery. The GPs reported that they were having to give less treatment, so there was less problems with side effects, less constipation, less nausea, things like that. And obviously the reduced costs. But I think the most important thing from our point of view was the positive impact on the patient's health and the fact that it was going to make their recovery from surgery better. So just some themes that came out from the comments that we collected from the GPs. What I think a lot of the GPs were really worried at the beginning about how to discuss this with the patients and how to get them engaged. But what they found was that once they sat down with the patients and talked through about the risks of surgery, and it was about, we're here to help, we're thinking about your safety. They weren't inviting the patients in saying, you're taking too many painkillers, we need to cut them down. What they were saying was, we want to help you. And they found by having that discussion with the patients that they were really keen to manage their pain with alternative methods. And they were really grateful for the information about the surgical risks because they didn't know about it. So just giving them that information almost empowered them to go, right, I'm going to look at these things with my GP. I'm going to think about what I can do. There was quite a lot of comments about people getting side effects from the painkillers, and they hadn't actually told their GPs this before. They just continued to take the drugs and just accepted that they were getting the side effect. So once the GP sort of said to them, right, we can think about cutting them down, and the side effects got better, the patients were really happy. I mean, there was a comment, somebody was happy to stop the painkillers because they were causing constipation, but they'd still been taking the drugs, even though they were causing all these side effects, and they hadn't thought to go back to their GP and say, I'm getting all these side effects. As I said, for some people, it was a really slow process. Some of them are continuing to have discussions about reductions after the Taper 2 project ended. There was a couple of patients who didn't feel like they could cut down on their painkillers, but what they said was they would agree not to increase the dose. So instead of constantly going back to their GP and saying, I'm in pain, I want more painkillers, they understood the risks of taking these drugs. So we thought of that as a win. And there was one comment about a patient who'd been taking gabapentin for more than 20 years, and they felt that the discussions that they had with them was really useful, and they were just doing a slow reduction. What was really interesting is about the patients started to think about alternative to drugs. So there was comments about people concentrating on their lifestyle, their well-being and their activity, especially the ones that got the social prescribing support. There was somebody who said that they hadn't needed their Oromorph since they started joint ACE supplements. So, you know, rather than taking Oromorph, they were just taking this little supplement. But obviously, nothing's perfect, so there was some learning that came from the project. So we found that the surgery date affected the engagement. So there was a couple of patients who they stopped taking their painkillers completely, and then for whatever reason their surgery was cancelled, and we almost lost the momentum, and they went back to their GP saying, I'll have to start my painkillers again, I can't manage, I don't know when my surgery is going to be. There was a few patients that said, no, my surgery's coming up soon, I don't think I can cut down on the painkillers, but actually after my operation, I'll come back and see you and I'll cut them down and stop them. So we saw that as a positive thing. We did have some issues with conflicting information. So we had a couple of patients who were engaged with the Taper 2. They did really well. They reduced their drugs down. They then went to see another doctor who put them back on their painkillers. So it just sort of negated all the positive things that we'd done. There was somebody who had chronic back pain, was admitted to hospital with a urosepsis. And while they were in hospital, they weren't taking any painkillers. They'd stopped their opioids, but the F1 in the hospital said, oh, you've got back pain, I know what will help that, and started gabapentin and naproxen, despite the fact that the patient still had some deranged renal function. So, you know, it's really difficult when you've got junior staff on the wards who aren't that confident and think, right, I'm going to try and fix somebody, and they don't understand the risks of these drugs. Somebody went to the pre-assessment clinic and was really proud because he'd come off his drugs and told everybody in pre-assessment about it, and they said, we don't know what you're talking about. So obviously we'd fallen down in our communication then. He was really disappointed that nobody in pre-assessment was telling him how well he'd done. And then the other thing that we've learned from this project is it's not all about deprescribing. We get very focused on that. But it's about, you know, making things better for people. So there was somebody who said, no, I can't stop taking my codeine. I'm waiting for a hip replacement. It helps me get out of bed and move around. I have to get to work. I've got to take the painkillers. But when they spoke to this lady, she said, all right, yes, I'll stop smoking. I'll look into that. So we were still making things better for her. And there was quite a lot of people who said, I'm not sure about deprescribing, but I'm happy for social prescribing support. So we were happy with that as an outcome. So a couple of questions that came up through the project that we were thinking about was, did the consultation method and the prescriber affect the outcome? So we didn't specify for the GPs how they had to do the consultations or who was going to do the consultations. We left it up to them because we were interested in how it went on. So there was one practice who did everything via telephone, and they recruited 20 patients for the project, and they recruited 20 for deprescribing, but actually they had one of the lower deprescribing rates. So although they'd managed to recruit lots of people, they weren't managing to cut down the painkillers as well as some of the practices that had the face-to-face discussions. And what's really interesting is the practice that was most successful in deprescribing was the one that received the most support. So they referred every patient for social prescribing, and they also discussed every patient with me. So I think that having that support from everybody working together made a real difference to those patients. And then one of the other questions was, did the social prescribing input improve the deprescribing rates? So it's difficult to know because we weren't sure. Did the people who agreed to have social prescribing support agree because they were struggling more? And were the people who weren't struggling socially, and were they the ones that didn't have the support and didn't need it? But what we found was that the ones that were referred to Waste to Wellness for social prescribing support did manage to reduce their painkillers more. So that's an indication that it really did make a difference. And I'm a big fan of the social prescribers. They did really well. Bit of additional information. So the GPs after the project, the feedback from them was that they felt a lot more empowered and confident. So the main support that they wanted during the project from me was not about how to deprescribe and what to do, because they knew how to do that. It was about how to have the conversations with people. And I think once they felt more confident doing that, then they really got on a roll with this. It's brought about a lot of new education and collaboration opportunities. So secondary care and primary care working together, and the social prescribers all working together. It's really made a difference, and it's really brought a recognition of the effectiveness of social prescribing for people with persistent pain. Because I think the social prescribers and the GP practices that I've spoken to, they do social prescribing for lots of chronic conditions, but they haven't really been involved with the pain patients. And I think that's an underutilised area. So I'm going to pass you on to Rachel, who's going to talk about the GP practice perspective.
Thank you, Angela. My name's Rachel Vincent. I'm one of the lead pharmacists. I work for NUth, and I'm actually based in the Inner West PCN in Newcastle. So the Inner West PCN of Newcastle has got 5 practices, and I was working at Prospect Medical Group, which has one of the biggest populations in the Inner West, which is about 15,000 patients. As James and everybody else has said in the presentation so far, most of the deep end practices are involving patients who've got poor health literacy, and they're in the lowest IMDs as well. So how did we go about Taper 2? I was asked by one of the practice managers to see if I would like to take this on with GP support, and we basically were given a list of patients from Radar, and went through really and prioritised who we would want to contact first. So within the list, we had patients on oxycodone, morphine, butrans, and a few on codeine and tramadol. And basically, we looked at who those high priority patients were and decided how we're going to contact them. Some patients were housebound, some we knew we would get through to on the phone, but some patients we wanted to make sure we saw them face to face. We didn't send any letters out because through previous experience, I think some patients feel very protective of their pain relief, especially if they're waiting for surgery, like Angela's explained. And I think it was important to build up the relationship and rapport with patients first. So most of the time it was a cold call just to say, you know, we're here, you're waiting for surgery, we're ringing from your GP practice to see how we can support you, and to provide like an opening really to discuss not only reducing medication, but smoking cessation and anything else that cropped up, like diabetes management. So one of the powerful things for me as a practitioner was the enablement it gave me, being able to refer to social prescribers. So we have social prescribers within the PCN anyway, but actually having that support when you are trying to reduce someone's pain control, it's great, because you might not always have that time and contact to be able to speak to the patient when they might want support. And I know through my experience working with Thomas, you know, he was able to speak to the patients more regularly maybe than I would, and just give them that degree of ongoing support and continuity. It was also a patient group really that I might not normally engage with, because a lot of the patients weren't polypharmacy patients. They might have only been on a couple of medication. They might have only been on maybe 1 or 2 pain control, you know, and laxatives. And normally, you know, from the sort of senior pharmacist perspective, we get involved in many complex polypharmacy patients. So we did a few face-to-face consultations, a couple of home visits, and a few telephone calls as well. And generally I did refer most patients to social prescribing, and just to see what Thomas could work his magic with, because we had a range of issues, from loneliness, people needing support with mobility because they'd lost confidence, because they'd been waiting for surgery for so long, housing issues as well. And all those other factors were barriers that potentially were stopping people thinking about reducing their pain relief. Being able to talk to people about the risks as well of having opioids during surgery was a real leverage, because patients weren't aware, and I don't think anybody had explained to them about some of the risks going into that surgery. Some of the alternative treatments that we discussed as well, referring to TIMS, and also Thomas managed to get hold of some funding to supply a few patients with TENS machines, which again helped with us being able to ask patients to try a reduction and to see how they got on, and not to just have a blanket no approach. So it was very much a collaborative support network really. Angela met with us quite a lot. We had a really good session with some of the other teams around the local area to share ideas of how we were working, and basically learning and supporting from each other. We also had a really interesting case which ended up with a patient being referred to a clinical trial with one of the anaesthetists, I think it was, for some cryotherapy, who had complex nerve pain, and potentially the use of some outpatient Penthrox as well to help with these dressing changes. And Thomas and Angela were keen in trying to get that to happen. I really enjoyed the experience of Taper 2, and I thoroughly recommend, if there are any further Taper projects, for all GP practices to get involved. And I'll hand over to Thomas now, who can give you his update on his results through his work.
Hello everyone, my name is Thomas. I'm from Waste to Wellness, and I was one of the 2 social prescribers that worked on Taper 2. So as part of our offer, we collected all of the qualitative data for the patients, and we managed to get interviews with 8 patients and 5 professionals. Looking at that data, it was broken down into 5 broad categories. What is life like for the Taper 2 patients? The role of the link worker, collaboration, outcomes, and we also had ideas for improvement as well. So the first of our themes is like, what was it like for Taper 2 patients? Broadly, themes were that it gave the patients clarity about the operations, including waiting times, clinical next steps, essentially what waiting well is all about. We identified unmet needs for the patients. Some patients said they wouldn't ever ask for help, but they were accepting help, and that was really beneficial. And some said that they felt having someone who wasn't part of their friends and family listen to them was really beneficial. All of my slides have some quotes. I'm just going to pick one. Feel free to read others if you'd like to. I think these slides are being shared. Maybe? Yes, these slides are definitely being shared. So you can read them afterwards. But I'm just choosing patient 6 here. Having someone who isn't family, who isn't tired of my moaning, it's reassuring. Talking has helped my mental health. When you're with the same partner for years, they know you and sometimes they switch off. Having someone who listens, someone who's different is really good. The next theme was the role of the link worker. We identified that the link worker was seen as a good go-between between the patients and the pharmacists, or the patients and Ange, the pain nurse. We had more time with the patients. We could offer more reassurance because we could listen to their concerns, and we can improve their motivation, and we can also help them with quitting smoking, which is quite a difficult journey. So I got patient number 1 at the bottom there. Very helpful. I feel more relaxed after a call and always feel better. I get anxious before a call, but I'm motivated after and look forward to getting things moving. I got a quote there from the professional number 2. An extra person to confide in and have contact with, to reassure them that they are not just a number on a list and they are being thought about and proactively cared for. We really quite liked that quote. Collaboration was another theme. Again, it's a good link up between the patients and us and the other professionals. So yeah, we had regular multidisciplinary teams which were arranged by Ange, and those were quite good for us to discuss concerns the patients had and get some advice and guidance for the patients. So then you got a quote from professional 3, good collaboration work and MDT discussions. And we've got quite a nice quote here from patient 8, who was very nice and sat through quite a long interview with me. So you can get stuck on what to do or where to go. It's that extra bit of support in life. It's not just a single thing like reduce meds. It's a whole holistic thing in one person. Rather than seeing person X for this and person Y for that, it's all here, all together in one place. When you're dealing with so much, it's so helpful to know where to go. When you get referred somewhere, you get an idea of what it is and how it's going to go. You trust that referral. Just knowing that there is something out there that you didn't know about when you're in the middle of stuff, you know even less, especially when it's for yourself. Helping yourself is so hard. So the outcomes that we found broadly were very positive for the patients. We helped the patients where they valued it most, and we can give them advice, recommendations around medication, send them back to the pharmacist or the GPs if they're struggling. So patient 2 said it's less stress for forms, but more stress for stop smoking. I'm getting there. It's better for me in the long run, all to improve my health in the long run. So patient 2 did end up quitting smoking through the smoking cessation service. She has had her surgery and had a very successful outcome. She actually lives at the bottom of a hill, and her goal was always to get up to the top without the use of a walking aid. And at our last meeting, she said she was managing that. So a really positive outcome for her. So yeah, here's another one. Referrals as well as the exercise group have made a big difference. Having a target to aim for each week. The referral to WISE groups for gas and heating was massive. Having a regular slot and having something to aim for has helped. Getting up to the group, being able to talk through before going to the group, putting my thoughts and fears in a logical way and challenging my thoughts. So a lot about mental health support for patient number 8 there. It's been really helpful. I can honestly say that having someone there who knows, having this and working with the GP makes me feel more in control. You advised me to see the GP when I was discussing symptoms. I ended up speaking with the consultant. They changed my dosage of one of my tablets. Since then, I have been feeling much better. It's better for me. I would have put up with it if I hadn't spoken to you. So we liked that because they felt like they were more in control of the whole process. So some other feedback. Overall, has helped patients living with pain. One patient said he would like to have had help with sleep, improved energy, and maybe some food advice. After we received this feedback, we referred him over to Healthworks, which I think James mentioned at the beginning, and also Riverside Support, who were partnered with us at the time. Some of the other feedback we had was that as external social prescribers, we can't see patient records. So we can't get access to clinical notes, but Ange was very kind in checking patient notes that requested it. One pharmacist said that being able to use Waste to Wellness for other patients who were going through opioid deprescribing would have been helpful. And some said that they would like summaries of how patients were doing. So we have sent some summaries to pharmacists after the process was finished. So a bit of data. So we had the deprescribing data for 39 patients. But 8 of our patients did not accept deprescribing. 22 had a significant reduction in opioids, and 7 discontinued altogether. But I think, as Anne said, 2 of those patients weren't on opioids or gabapentins, but temazepam, and 1 patient reduced. As part of our Waste to Wellness process, we do what's called the Wellbeing Star, which is a star made by the company Triangle. We do 1 at the start and 1 after 12 weeks. And the idea is to look at different areas of the patient's life and find out what they think is the most important. So it is a self-reporting tool. Higher scores are better. And you can see in the first column, you've got what their starting scores were. In the second column, you've got their scores after 12 weeks. And the third column is the percentage change. And the big changes are in patients feeling more positive, more comfortable in where they live, and managing their symptoms. And this suggests that they're managing their pain better. They're feeling more comfortable where they live because we've supplied them with some adaptations, and they're generally feeling more positive. We also collect some data with the EQ5D from the NHS. And in this, again, it's a self-reporting tool. In this case, a lower score is better. So in each category, they say, like, I have no problems with mobility, slight problems, moderate problems, severe problems. So you ask them again, start and after 12 weeks, and we can see again, we've got big reductions in how anxious people are feeling, a reduction in how people are perceiving their pain. So which backs up the data we've had earlier. The patients were feeling better and feeling less pain. And that last one there is a question, how are you feeling today? And there was a small increase in people feeling better at the 12-week mark compared to the start of the intervention. That is everything from Waste to Wellness. I don't know who I'm handing it back to now. Thank you very much.
Thank you, everyone. Thanks, Thomas. I think it's back to me. That was brilliant. Thank you so much. What amazing work. Now, we've had some questions come through. If we do a little spotlight on the speakers, and I'll start asking these questions. I've written some of my own down. So if you want to take, I don't know who wants to take the first one. The first one that's come through is from Mohammed Javid, which says, rightly, there's recommendations about tobacco cessation, but why recommend alcohol reduction when evidence and World Health Organization inform us there's no safe level of alcohol intake? Now, I think this is more an opinion piece than anything else. I don't know if anybody feels comfortable to take it, but why is the CMO and Public Health still recommending 14 units of alcohol a week and not following the evidence base and pandering to the powerful alcohol lobby and the Treasury in view of the high government earning revenue? Now, I can pose that question and we can air it, but I don't know if anybody feels comfortable to offer an opinion there.
So I think surgery is very different to what we're talking about within public health and the health of the nation. I can't comment on an exact level where we should be. Should we be saying we should stop it completely? What we do know from my point of view, and we've done a study on this previously about risky drinkers. What we know about risky drinking is it increases your surgical complication rates. We know that. But where that level's got to be, we don't know. For me, within the Waiting Well programme, if we can help people cut down or think about alcohol, of course, it's going to help your weight. And weight management is probably the biggest issue that we have when it comes to elective recovery. Diabetes, hypertension, obstructive sleep apnea. We've got an massive expansion in elective treatment hubs across the country. All of these have BMI cutoffs. So anything that I can do to help someone lose weight, and be that helping them cut down on alcohol, which helps cut down on calories, is a win.
That's a great answer. Thank you, James. And thank you for your question, Mohammed. So the next question came from Gary Westerfield, which I think Faye has responded to in the chat. So Faye, hello Faye from I think you're from Lancashire, thank you. And was there any consideration of having substance misuse services supporting the deprescribing? In Darlington, we're supporting several GP practices with the outcome. So from a waste to wellness point of view and social prescribing, did you link into any other services in the community? And I've heard HealthWorks there, but were there any substance misuse services engaged, or was it not necessary?
We didn't have any partnership engagement, no. And we did have a few VCSCs that would help people who had difficulty with mobility, such as Search in Newcastle, that was very popular. So those who were waiting for hip and knees especially, you could get support, but nothing around substance misuse specifically.
Thank you. Thank you. Angela?
I was just going to say, with this project, we weren't targeting people who were taking massive doses of opioids and gabapentinoids. It was any level. So, and a lot of them, it wasn't, we didn't really see it as a major problem. They weren't struggling to come off the drugs. I suppose we could have engaged with the substance misuse teams if we'd needed to, but I don't think we actually needed to for the patients that we recruited.
Thanks, Angela. Faye's gone on to say that she's from a different ICB, but they had a pilot where 29 out of 51 participants engaged in reducing opioids. But again, I think you make a really strong point there that we're looking at a specific cohort of patients here. But it sounds as though there was, thank you, there was those patients were quite complex. The local drug and alcohol team support worker worked with them in practice, particularly around reducing stigma. Thank you. Yeah, if you want to share that information, that would be great. Then we've had, so Faye also asked, are your social prescribers trained in chronic pain? Did they have, and now Jules Coulson has answered that, saying yes, there was specific social prescribing link workers are specialists with extensive training, and there's a project focused on persistent pain symptoms, including chronic pain, in addition to this project that Thomas works on, which is, there's a link, and again, we'll pull all the links together. So that specialist training, how long did it take? Can you explain anything about it? James, your hand's gone up straight away, thank you.
I would say we're slightly different in that we probably have done quite a bit with Thomas and Kieran and the extra staff from Ways to Wellness and HealthWorks around surgery and what actually that means, which is something completely new and different. We don't see social prescribing in secondary care, but we were able to take them around the hospital, show them what the patients expect when they're coming in, understanding what waiting lists are and what pre-assessment is, and all of these other angles of the hospital setting. So I can't comment on the training for chronic pain. This was a slightly different perspective on things coming from secondary care and surgery. And actually what I think we found was it's that surgical part that patients are the most concerned about once they're on a waiting list. They don't know what's happening. They don't know what to expect. And that's the training that we put in much more than, and it wasn't, you know, it wasn't high level ridiculousness about everything, but we've certainly got some we've got training come down from NHS England that is free to use around the surgical journey and what complications are and why this is all important. So I think we went more down that line than specifics into chronic pain. And of course, we've got Angela, who helped a lot from my perspective, who's much more knowledgeable than I am when it comes to anything around pain.
Yeah, and I'm presuming, James, so from a very old clinician who was a physio at one point, I can remember being a junior physio and having patients coming to pre-op for hips and knees, and them coming into the wards and us showing them around the wards before they went home, so they knew where they'll come. I'm presuming that does not happen anymore. So just having somebody who's got some insight into that to share is reassuring.
We do have joint schools, so they do get an hour with a physio, and some of it's going online, etc., etc. I don't think it opens itself up to this population of patients.
Yeah.
The socially deprived group are the ones who are being excluded from this. I'll forever see people showing, oh, well, we've got this brilliant surgery school and we compared it to people who didn't engage, and those patients did far better. For me, it's got nothing, they were going to do far better anyway. And what you've done is widen the health inequality that,
yeah.
And that one-to-one support where people can ask questions about anything that is worrying them is far better than these big, you know, you've got 20 people there and it's the person with the sharpest elbows gets to answer all their questions and the other people sit there or don't turn up at all.
Yeah, yeah. So there's a space for group work, but there's also a space for that individual one-to-one, and it seems to be those more socially disadvantaged, possibly more vulnerable people benefit more from that one-to-one support than those group sessions. Yeah,
100%.
Thank you. So we've shared so we're looking at, Julie, do you have a training package to share? No, there's a chat and an email address there for you, Faye. So again, Natasha's asked, did you explore the reasons for people not accepting social prescribing just out of interest? Or is it they just didn't and they went onto deprescribing purely? Or have you got a gut feeling? Or can you just not answer that question? That's fine if you can't.
I think you always find it very difficult, don't you, with the people who say no to someone getting any decent information coming back to us. And we've always had this. Can we approach them to do sort of this qualitative type work, even if they've said no? And I think we do need to work on that. And we do need to see why people have said no, because the more people we can get into it, obviously, from the data that we're getting, is showing an impact.
Yeah. So just as me thinking of that through, just thinking of the forum that we're in, do you think it would be worthwhile asking the question, when you get a no, don't be frightened of the no, but explore it further. Can I just ask you why you've said no, just so I can note that down for future? I think that's one thing we miss. I think we miss it in when we make every contact. How do you feel about your smoking? I'm not interested. Can I ask you why you're not interested? It's that, how far do you push it? And I think we can be exposed to quite a lot of pushback sometimes, but we're in it for the goals. So do we offer social prescribing? No, I think we've asked that. We do offer social prescribing in secondary care through our space pilot project. So that's the Ways to Wellness. So is there any more questions coming through? Because if not, I always have a few. So my question is, Oh, go on, Thomas.
I was just going to say about people saying no. A lot of the time when we're working with people, you wouldn't offer something on the first meeting, because they're less likely to accept it from a stranger. If you spend the time with them, get to know them, find out where they are, and you can meet them there, and then you can offer recommendations, and they're more likely to trust you, more likely to push themselves out of their comfort zone if it's coming from a trusted source.
Yeah. It's getting them into that trusted source initially.
And,
absolutely.
And we've got the time to do that.
Yeah. Charlotte.
It wasn't actually on this point, it was just about the question around alcohol, but I'll just pause in case there's something else that otherwise I'll come back to it.
No bother. James.
I was just going to come in. I think what we showed was that it's probably the professional who's asking the questions that we need to really hone in on and get a way of doing this. Angela showed that, one practice, they engaged loads with the deprescribing angle, but we didn't get any into the social prescribing, whereas another practice was much more, you're doing this, let's do this. You can tell how we deliver that information to the person is going to be why they say yes or no to something.
Yeah, that's great. Thank you, James. Charlotte.
It was just to come back to the question around the alcohol, because I just thought it was worth just touching on in terms of there is in public health, there is an acknowledgement that alcohol is a leading cause of ill health, particularly in people that age between the ages of 15 and 49. And we do acknowledge, that even in the Northeast, we do have the highest alcohol-related deaths in England and continue to do so. And there's definitely an acknowledgement in public health that there is no definitive safe level, but the CMO talks about that recommendation about the 14 units to keep health risks to a low level. But really, helping people cut down, having that conversation, harm reduction and such like, it's a really important aspect of, any kind of patient contact, including identification and brief advice, the screening tools, as well as then considering treatment and recovery services where required. And of course, there's more that we could do as well in that space in terms of consideration of wider regulation, minimum pricing, minimum unit pricing, thinking about advertising and how we can reduce that and such like. So I just wanted to kind of acknowledge that there is an acknowledgement around that question. So thanks.
No, thank you, Charlotte. Just as you were talking, Gary Besterfield's come in and said it's a skill to elicit information about harmful behaviours such as alcohol. And speaking to midwives who have to ask that question to pregnant mums, it sounds it's a real tricky question to ask to get a truthful response from, because there can be no judgment there if you're asking about those illicit behaviours. It is, you're absolutely right, Gary, it's a real skill to ask those questions. Now I've got a quick question. Oh, Angela, go on, beat me to it.
I was just going to say about what Gary's saying, there's a skill to asking these questions. That was one of the things that I helped the GPs with quite a lot, how to ask the patients the right questions to get accurate answers about what drugs they were taking. Because if a patient's got a bottle of Oromorph at home, if you say to them, how much are you taking? They're going to say, 5 mils 4 times a day, because that's what's prescribed. But if you actually say to them instead, do you measure your Oromorph or you drink it out the bottle? You're almost giving them permission to say to you, yeah, just drink it out the bottle. And we know a lot of people drink it out the bottle. So it's about, thinking about those right questions to ask. And that's what the GPs really liked, because a lot of them hadn't thought about that. They were very much just, I think they're so busy. They're very focused on, right, ask them this question, ask them that, get through that, rather than thinking in detail about what can I ask to get an accurate answer so that I can help this person.
Yeah, no, I think that's very true. I think so. Jumping on the back of that answer that you give me a great segue there. Thank you, Angela. So I am hearing that there was lots of upskilling here, that this project translated over into confidence to ask questions, to have conversations, to go there. Has any data or information been collected about how this project upskilled and translated into other areas? So we know that in our region that we are opioid prescribing outliers. We've your project's looked at a very specific cohort, socially disadvantaged, on waiting list for surgery. What about, is there any understanding of whether or not this information, this skill translated over? Is there any data around that to say, you know, GPs and pharmacists felt more competent to have to ask the questions of people who were on opioids who weren't on waiting lists? Did it translate over at all? Are we aware?
So I got some feedback from quite a few of the GP practices that where they were saying it was really, really helpful, and especially when I did teaching for the whole practice, that I'd given them quite a few tips and tricks, and they were using those for all the patients, and it was making them think before they started the drugs. But probably Rachel's the best person to answer that question rather than me.
Yeah, I think obviously, you know, having this experience did give you the confidence to continue having those conversations. And actually, you know, once you've had one success, and a lot of it comes down with, like everyone said, how you talk and how you deliver to patients, you know, being positive, being realistic, being human. You know, not everyone can and, you know, has the resources to do, you know, lots of all these different exercises and get out and about, and you know, some people don't have family, and it's just being that human person at the end of the other side of the consultation, listening and realistically understanding what that person's going through, that makes the big difference, I think. And, you know, yes, sometimes you can't teach those softer human skills. I think sometimes you either have it or you don't. But I do think people learn through experience, and shadowing other practitioners as well. So I do think that going forward, you know, there's a lot of work still from the ICB for GPs and practice to reduce gabapentinoid prescribing and opioid prescribing, but it has to be not prescriptive. Just a pharmacist to say that. It has to be really, you know, like I've said, you know, consider all the human factors and make sure it's collaborative, you know, like we've already touched on. Ensure all the people working in the practice and the team are aware of how to approach things.
That's great. Thank you, Rachel. Samina.
Yeah, I just wanted to chip in there, because I think from taper 1, we did see that practices started implementing systems, and they shared things like letters and ways in which they were trying to get in touch with patients. And I think that was, again, that kind of protected time gave them the ability to instill ways of working within the whole practice, and hopefully take that forward. And a lot of them worked in tandem with their pharmacists as well to try and do the deprescribing work in taper 1. So I think that helped with sharing the burden, sharing the load of that kind of quite highly emotive work sometimes, or kind of emotionally burdensome. So yeah, I do hope that it has upskilled some of those practices to implement some of those techniques. And I do agree with what Rachel just said, that, you know, there's a lot of work to do, but making it flexible and not too prescriptive in terms of how it's achieved is really important, so that practices can do that and tailor it to the needs of their patients.
Yeah. And so just quick, did you find there was enough resources in the community to allow patients to get the support that they needed? So we know there's Ways to Wellness, Health Works. Were there organisations outside of that you regularly tapped into, that you already had all links with, or could you see any gaps?
Well, I think I mentioned, like, the other charity was like Search, which is a really common one. There was also Riverside, which we use quite a lot. And we had an unofficial link with like Tyneside Women's Health for a few of our patients. But there was there's lots of gaps geographically. So like Search is over in Fenham, but if you're in Byker, there wasn't a similar thing over there.
Yeah.
So it was more about patient access, we found. A lot of these people are in a lot of pain and can't get on the bus, can't afford taxis, so they can't access services. That was the gap we found, was how things are spread geographically.
Yeah, and I think that's come through with the citizens jury work that's being presented on the 13th of November, that local hubs, that so it's accessible. It's almost your 20-minute cities, isn't it, where everything's accessible in a 20-minute, which hopefully we're working towards. That's been brilliant. Thank you. So just to recap anything that's come through. So Julie Coulson has mentioned the relation holistic model of working is common to all our prototypes. So this is Ways to Wellness, each of which applies to a specific niche to demonstrate how it can apply to different contexts and to different populations with data collected in each case to help the system carry learning forwards. So that's great. Thank you, Jo. And is there plans, this, so we know this is taper 2, but there's other variations of this and it's spreading. Will the taper project stay within a surgical framework, or could it spread wider to more, so those patients who are on opioids? Could you see it could translate over to the non-surgical patients? Yeah, I've got some nods. Yeah, lovely. Thank you. So as we've said, this will be recorded. It has been recorded. The speaker presentations will be circulated and they'll be popped on the Futures platform. And we will find a way to circulate the recording in other areas as well. We'll share it with the Taper 2 team. Our next meeting, which will be the last one I will be hosting, so people might be very pleased about that, on the 26th of November. We're hoping it's either going to be on a women's health theme, and failing that, it might be something to do with the citizens jury, because we'll have had all the feedback from the meeting. So it'll be one or the other, which will tick the box of the PPI that was requested at the beginning of the year as one of the themes. So it'll be one or the other, but if we pull something together for women's health, anybody who's interested in hosting, you may already have a packaged meeting all set. You just need to host it. Thank you. Thanks, Helen. So if you no longer wish to attend these meetings or receive updates, you'll be contacting me, because this is Yo-Yo's last session supporting us. So can I just say thank you so much to Yo-Yo for being the person in the background for the last 3 years. You have been amazing and you make me look an awful lot better than I actually am. Thank you. So without further ado, you've got 5 minutes back. Thanks ever so much to all the speakers, and thanks to all of the audience for attending and engaging. That's been brilliant. Thank you so much. You take care now. Bye.